Yeah, let's just do a quick assessment. So I'm going to be lying on your stomach. So I change what I just said. Yep.
With my head to that one.
Yep. And let me just steal up the pillowcase. Okay. Once again, similar to the cervical spine, I encourage you to be consistent on how you set your patients up. And so I'll show you the way that I set it up, right, is usually like this. I will almost always put a pillow underneath their legs, and then my other differential, depending on how much lordosis they have and how much discomfort they're in, I would also stick a pillow up underneath their hips as well. All right, so if we're looking at upper thoracic, right, so you want to take up your tissue slack, and then regardless of whether you're here or there, I tend to have my proximal hand on the superior aspect, and my contact points are going to be my pisiform process just there on both hands, and then I'm going to come together, and I'm not going to thrust. I'm just doing my oscillations as far as identifying the areas of hypomobility. And because we're wanting more of the upper thorax, I'll start kind of like at the scapula and work my way from CT junction up and down. And then if I want to be a little bit more specific, I can come in with my thumbs. If for some thumbs are like a challenge, then I can do my UPA by pushing over my thumb with my thenar eminence of my right hand. So I have a dummy thumb, and then that can kind of protect my joints from being too hyperextended or too mobile. All right. And then if we're trying to be strategic, I don't know, Jess, I feel like that is probably the worst for me. What about you?
Yeah. I can't tell.
Okay, fair enough. All right, so then, yeah, we'll shoot for, again, it's kind of like, I don't know, let's call it T3. And we won't be doing a rib technique at the moment, so we'll stick with that high position. All right, we turn it back over. Again, I am almost universally will always use the flat side of the table rather than the head because of the contours that can otherwise influence my thrusting surface. Okay, so a couple of consistent things that I will do. I always put the table as low as I can. It just helps for not only for the leverage, but also for my ability to kind of get up and over. And then if we just move the vantage point here, I think that'll be helpful. Okay, and then I'm going to have the patient move all the way over until you can feel my leg up against your body. Perfect. Okay. The other thing that I do is I always kick the proximal leg straight. And the reason being is because that adds just a little bit of an obliquity to the pelvis, and then it also adds essentially if I'm like this, right? If I'm going to exaggerate it, it starts to gap this side of my body as I am more flexed here and more extended on this side. And then as we spoke about in the initial portion of today, having a towel or a blanket to take up the tissue slack, right? And we definitely don't want the W, right? We really want the V. And then the other thing that wasn't stated but was performed was that the far shoulder is on top. There are instances where person has pathology here, and thus I will use I'll switch the arms. But essentially, go ahead and switch the arms just for a second. So then when I thrust, it kind of pushes her into more that W position, rather than if this arm is on top, when I push, I don't get that slippage necessarily. Okay, I will also encourage them to like really kind of grab or hug themselves, and then I also give a preliminary bump that's what it's going to feel like. All right, just to make sure that they're okay with it. I consistently find that my hand likes, and I am more successful when I hold on to something. So the grip that I usually use is like this. Sometimes I'll use the pistol, but the spinous process is going to go between my fingernails as well as the palm of my hand. And then I'm going to kind of pull down like this. You're going to see your elbows come up. And it's a mistake to push them back down, at least for the upper. I'm actually going to step up to her elbows and then drop through it. But similar to what we saw Colby's technique earlier today, is that we do want to find that rocking technique where we have the biggest contact. You just don't want to hang out there for too long. Actually, Jess, can we go to the other side so we can see the purchase? Otherwise, they won't be blinded to it. So we're just going to reverse everything that we did. So we're going to, yep, perfect. You're going to keep coming towards me. Okay, how do I remember which foot is up and which foot is down? It's because it helps them, foot helps them to leverage themselves over. All right, and we identified the level in question is going to be right almost like T3. So I'm going to come above it, and then I'm going to essentially supinate and pull down as I pull her over. There's the elbows. I'm not going to pull them down. I'm going to use that pull down, that tractioning, to then get up and over her like this. And then you can, if you need to, add the flexion that we spoke about before. And my force is like straight down. Again, I can leverage here and then drop into it. Yeah, I think that those are the key points.